So today we're going to do Today we're going to discuss a little bit about safety in pregnancy and specifically how it relates to the medications we use and the imaging that we use, because these are both really major things that we need to be aware of. And I think it's really important that we have an idea of what's behind the things that we use so that we can also do shared decision making with our patients and counsel them on the pros and cons of the treatment that we're providing and the imaging we're requesting and so forth. So next slide. So I don't know if any of you guys are aware of this, but about 90% of prescription medication has absolutely no safety data in pregnancy. And the reason for this is that people are simply too scared to do these studies. It's become the norm to, as a standard, exclude pregnant patients from new medication trials and drug trials. And this is largely because everybody wants to do no harm, which is fantastic. Obviously, we don't want to harm small babies and we don't want to harm pregnant mothers, but this leads to a complete vacuum of information. Nobody knows what new medications are going to do in pregnancy because we simply can't do those studies. And as this quote says, there's little incentive to investigate how these babies fare after exposure to medication. When it comes to research, there's a sort of no regrets policy, as in let's not do anything so we don't have any regrets.
I'm going to ask, please, guys, can you mute yourselves? Snap. Snap.
Google Live. Good Live.
Tammy, have you muted me? Can everybody hear me?
Yes, we can hear you.
Okay, great. So if you have a look at this chart, you'll see that in the embryonic period is really the greatest danger for all of the teratogens, and this includes both medication as well as imaging. And that's really only about the first 8 weeks or so that the patient is pregnant. And this danger comes in because often people are not even aware that they're pregnant during this very early period. You know, they've perhaps missed one menses cycle. They're not really regular periods. And so a lot of patients aren't even aware of the pregnancy during this time of greatest risk. And then once people become pregnant, we're all extremely aware of the dangers of medication and radiation, and patients don't get the imaging that they need, and they get denied analgesia and denied chronic medication. But really, a lot of the danger has passed by the time that we're aware that the patient is pregnant. And it's quite important to just be aware that teratogens are incredibly related to the time of that specific organogenesis. For a lot of medications, there's only a very tiny period during the pregnancy that you should be avoiding them. And after that, in the second or the third trimester, many medications are actually very safe because the organogenesis has already happened. Next slide. Okay. A lot of our concern for safety in pregnancy really comes from this history. I don't know, guys, can we mute ourselves? Thank you. I don't know how many of you are aware of the thalidomide scandal, as it became known. So thalidomide is a medication that was initially marketed in the 50s, and it was marketed initially as an anti-anxiety medication, a little bit of a sedative, but it soon became prescribed for absolutely everything, including morning sickness. And it was advertised as being incredibly safe and having no side effects, but the reality is there was actually just no data. No pre-market safety tests had been done because it wasn't a requirement in those days. There was no legislation about pregnancy trials and drug safety. And so this medication was really just marketed like Smarties to pregnant mums. And it took approximately 5 to 10 years before this amelia and the severe teratogenic effects were actually linked to the thalidomide. It took a very long time for this medication to be withdrawn from market, and there's estimates that anything between 10,000 and 50,000 children were born with no limbs or deformed limbs. The majority of them died shortly after birth, but several people are still alive today. There's actually a thalidomide society that looks after the interests of these patients. Many of them are, of course, now quite old already. They have meetings, and they actually driving a lot of the awareness about drug safety in pregnancy. And it really was this big scandal with all of these patients being harmed that led to our modern drug trials. Before this time, you could basically develop a new medication and market it with very, very little evidence and with absolutely no safety evidence. The only trials that had been done on thalidomide were in mice. There were no pregnancy human trials before coming to market. And after this, the medical community and governments and so forth came together and said, you know, this really must never, ever happen again. We can't do this to patients after we've assured them that what we're giving them is safe. And so our modern period of drug safety really developed from this terrible tragedy. And at least some good came out of it. Next slide, please. So we're going to start with a few case studies just to start our brains off this early morning. We've got a 19-year-old female. She was involved in a PVA and she's come into the ED unresponsive. You order a pan scan and incidentally, we find a fetus in utero. What are the implications for the fetus? Anybody would like to answer? Have a go. Please unmute yourself if you're going to answer.
Andy, you're online. Why don't you answer the question?
Thank you, Tammy. I can't see who's online on my phone.
Can you hear me?
Mm-hmm.
Okay. So, okay, to me, that fetus looks at least second trimester. So my thinking is that, okay, there is a significant dose of radiation with a pan scan, but as Jana said earlier, most of the kind of damage to that would affect fetuses during organogenesis would have been done in the would occur in the first trimester. So I think, you know, if we have a PVA unresponsive concern for an abdominal injury, it's kind of a benefit risk ratio. And here we didn't know she was pregnant, so I think it's still the benefit of getting the information from the scan outweighs the risk to the fetus. That would be my thinking in this case.
Okay, you're absolutely right. And really, you know, whatever the risk to the fetus was, it has now already happened. The pan scan has been done. Hopefully the injuries have been identified. And in most cases, the injuries from a traumatic event are a bigger risk to the fetus than any radiation that you could impose upon them. In the early days of CT scan, when we didn't know as much about this technology as we do now, there was a very strong school of thinking that said that if a fetus has been exposed to any accidental radiation, it's safer to terminate the pregnancy because we didn't know what the risks were. And luckily, we've moved away from this fairly ridiculous advice. There's no longer any kind of advice that if you've accidentally irradiated a baby, you should counsel the mother that there's going to be permanent damage. You should suggest termination or give that as an option. But this is how scared we used to be about radiation. We had this enormous fear that we're causing very permanent, very severe harm to babies. And luckily, as the technology has moved on and we've had several studies and there have been cases of fetuses irradiated without our knowledge, we've come to realize that this is actually really, really safe technology. Next slide. Okay, a 24-year-old female presenting with breakthrough seizures after she stopped her epilim 4 weeks ago when she found out she was pregnant. She went to Google epilim and she came across this very scary looking article with these pictures of these congenitally abnormal children, and she was so frightened that she stopped her epilim. She's now got seizures in the ED. How would you manage this patient? Tammy, can you nominate someone to answer, please?
Okay, Joe, why don't you answer the question for us, Dr. Osawe?
All right, thank you, Tommy. So we've got a 24-year-old coming down with breakthrough seizures in the ED, and she happens to be 4 weeks pregnant. She's still basically within the period of embryogenesis. So sodium valproate is actually one of the antiepileptics are actually teratogenic. But coming now with seizures, I'll be more worried about the patient because resuscitation of the mother if you resuscitate the mother well, you also resuscitate the baby. So my worry right now will be the mother. So what do I do? So usually our ABCs, place her in a recovery position, ensure her hair is patent, obtain an ideal access to still having ongoing seizures. I want to avoid that. So our first line medication for this patient will be benzodiazepine. So give a benzo to break seizures. If seizures are aborted, then we can go ahead, just to continue resuscitation basically, and ensure that she's stable. Other medications basically we use in pregnancies that are actually quite safe is said to be carbamazepine. So what we do going further would be to stop the sodium valproate, and maybe cancel the mom when she gets back to our baseline.
Okay, good. So I like that answer. I agree with you completely. Resuscitating mother is resuscitating fetus. And really, all of our emergency management for seizures is quite safe in pregnancy in all of the gestational ages. The only time you should really be cautious with benzos if it's in the peripartum period. So if the patient's about to deliver, you really don't want that respiratory depression from the benzos if the baby comes out. But other than that, you can actually give them as emergency treatment. And as you say, epilim is a known teratogen. We should start her on a more pregnancy-friendly regimen for her epilepsy. But the point I want to really make is the epilepsy still needs to be treated. Okay. There's several studies that show a far increased risk of both maternal and fetal mortality in untreated epilepsy in pregnancy, far worse than any of the medication-related complications. So not treating the epilepsy because you're worried about the fetus is simply not an option. We do have to counsel the patient on the safety and the risks of epilepsy medication, but the message we really need to get across to patients is that stopping your treatment because you're pregnant without going on to an alternative is just not a safe option for you or for your baby. Next case, please. Okay, we have a 32-year-old female who presents with features of septic shock, and she's noted to have a tick bite issue. She requires intubation for a low GCS. Which induction agent, inotrope, and antibiotic would you consider? And this case really hit close to home because I got tick bite fever during pregnancy. Luckily, I never ended up in hospital, but I was quite concerned because even my gynae couldn't give me very clear advice on what's the safest antibiotic to use. So who wants to have a go?
Let's try Amy.
Leslie and Fatima are now all here, so we'll all try together. Okay, induction agents. Sure. We have a pregnant lady with tick bite fever that needs to be intubated in the ED. What induction agents, inotropes, and antibiotics would we use? So we can't, okay, so for the antibiotics, we can't use doxycycline in pregnancy. But I'm not sure what antibiotic we would use for tick bite fever in that case. So we have to use what induction agent?
So I'm trying to think. Agent is we do a rapid sequence.
But with which agents?
Okay, so you
can we use propofol in pregnancy? We can use propofol in pregnancy, but she's in septic shock, so we probably would not want to lower her blood pressure. in that case, we'd probably use ketamine for the induction agent. And then for the inotropes, to be honest, I'm not entirely sure if any of the inotropes are contraindicated in pregnancy. I would probably say that we'd start on noradrenaline based on the fact that it's a septic shock, but I don't know if there's any contraindication in pregnancy for that. Sorry, not the best answer. We're not entirely sure.
Okay, that's fine. The case is really meant to just make you stretch your mind a little bit to realize that despite the fact that we're treating pregnant patients every day, even as medical professionals, we're not always sure what we should be using for these cases. And the point I want to make is if you need to phone for help, please do so. Okay. If we're not sure what we can use, phone the gynae and ask them what they think is safe, or go online to Medscape or to any of the apps that you use and quickly have a look through the pregnancy safety data. Okay, there's no shame in
or phone your
Googling
consultant
to just,
on call. That's another thought.
just make sure, or phone your consultant on call. But if you are unsure, please ask for advice, because we don't often think about these things. We don't see that many pregnant patients who come in extremis. But when we do, we really want to make sure that we're doing the optimum thing for them. Okay, to answer the case, in induction agents, propofol is safe, you're right, but with the patient being in septic shock, that's always a risk that we're going to make them hypotensive. So you can actually use any of the induction agents that we would use in an emergency. Okay, ketamine, etomidate are both acceptable in pregnancy. For inotropes, you can use any of the inotropes. There's some theoretical risk that adrenaline could cause some vasospasm of the blood supply to the placenta. But really, as Joe said, resuscitating the mother is resuscitating the fetus. So if you can get the mother's blood pressure up, you can fluid resuscitate her, you can stabilize her. Using your inotropes will most likely improve the baby's case as well, despite this fairly theoretical risk of vasospasm to the uterine blood supply. Okay, and then antibiotics. When I phoned my gynae to say that I think I have tick bite fever, he said, "Oh my goodness, that's interesting. I've never had a case in pregnancy before." Which really wasn't very reassuring. So both of us went to Google and we decided that azithromycin looked like the best option. There were very, very few case studies in the world. And I had to go into a course of azithromycin for 5 days, and luckily I was fine. But as you said, doxycycline is definitely a no-no. So you have to use an alternative that is likely to provide the same spectrum of cover and that is not known to be a teratogen. And as I said, even with antibiotics, a lot of medications we simply don't know, but we can at least avoid the ones that we do know are definitely a bad idea. Next slide. Okay, here's your little cheat sheet that you are welcome to keep on your phones when in doubt. And this is just a list of your go-to medications, your second line, and then things that we specifically want to avoid. And you'll see there's really not severely many of those. Most of our resuscitation drugs are perfectly safe in pregnancy, or at least we're not aware of any specific side effects. There are certain drugs that we have more data on simply because they've been in use for longer. You'll see if the anesthetists are doping a pregnant patient, their go-to drug for induction will always be propofol, because propofol is very well used in anesthetics. So we know that this has been used for a very long time. It's most likely very safe. With our paralytics, cisatracurium is really the go-to option simply because of how quickly it gets broken down and eliminated. But Sux and Rock are perfectly fine if we don't have cisatracurium, which we usually don't in the ED. Okay, as we can see, we should avoid midazolam, but specifically perinatally. And again, it's more because of that risk of neonatal respiratory depression than anything else. Okay, for our asthmatics, for our patients in cardiac arrest, for our patients with GI concerns, there's really very few drugs that you need to avoid. So just have this list somewhere in the back of your brain if you're able to, or keep it on your phone, which is really everybody's brain these days. Next page. And really this list just goes on to explain to you exactly what you should be avoiding, which is very few things, as I said. Okay. As you saw there, for seizures, we've said most of our medications are safe. even for micro, the antibiotics, we know the penicillins are fine. We know most of the antivirals are fine. Many of the antifungals are actually fine as well. We'll just chat a little bit about fluconazole. We really only want to avoid the tetracyclines and the sulfonamides and fluoroquinolones because we know that those ones aren't safe, but we've got good alternatives. Next page. Okay, for our psych patients as well, benzo is perfectly fine. And then for tox, basically everything that we have common access to in terms of antidotes is actually safe in pregnancy. And I just want to make that point quite clear. We're hardly ever going to use methylene blue because it's out of stock in the entire world. And I've never had to use penicillamine for anything. But if you do get a pregnant patient who has overdosed, please treat the overdose. Okay, please give the antidote. They are all safe in pregnancy, and the risk to the fetus from the toxin far outweighs the risk of any antidote that we have available. Okay, radiology we'll get to, so we won't go into detail for that now. Next slide, please. Okay. Specifically, a word on analgesia. Okay. As with everything, least is best, but you still need to manage your patient's pain appropriately. Okay. There's very many studies that show that pregnant patients with pain are undertreated because of a perceived fear from the medical staff that they shouldn't be giving drugs to pregnant patients. But really, the majority of things that we have are fairly safe. Okay, so treat your acute pain appropriately. Much of the data around analgesics actually show that there's more of a risk with long-term use than with acute or stat doses. Okay. Panado is still recommended as the safest medication for pain in pregnancy. The NSAIDs, ideally not, because Panado does the same thing. Okay. Opioids, again, stat dose is perfectly fine. Short-term, low dose, avoided in a chronic use. And then ketamine, we love in the ED. There's really very little data. I think using ketamine as an induction agent is fair because it's so cardiostable, which is safer for mom and baby. But we've got better analgesic options than using ketamine purely for analgesia in pregnancy. Next slide. Okay, I'm not going to read through this entire list. You guys are welcome to go through the slides afterwards. These are the drugs that we know are teratogenic. And on the next slide, the ones that are in bold are the ones that you'll commonly encounter for use in the ED. The ones to be particularly aware of is amiodarone, because we do use it as an antiarrhythmic fairly often. We want to be careful with our steroids. Warfarin is a complete no-no, and then specific antibiotics that we know are not great. Okay, nobody should be using ACEs in pregnancy for hypertension. We've got better options. And then, as we said, some of our anti-seizure medications, we've got safer options than valproic acid and phenytoin. So just be aware of those because we do use them as emergency drugs. Next slide. Then just a little word about over-the-counter medication. Okay, every pregnant patient is going to at some point have reflux, constipation, severely blocked noses, which I never knew was a symptom of pregnancy until I got it. Okay, so severe rhinitis. And the majority of over-the-counter medications are probably fairly safe. Okay, prenatal vitamins definitely we should be giving. Anything that is a nasal spray, because it's so localized, doesn't actually get systemically absorbed, so that's perfectly fine. Most ointments, most antacids, most hemorrhoid treatment. So just have a look at what your patient's getting from the chemist or the pharmacy to treat their day-to-day symptoms as well, so that you can advise them on the safest options. We specifically want to avoid the NSAIDs, as we've mentioned previously. Aspirin is a no-no unless it's been prescribed by a doctor, okay, to prevent the risk of PET. Something that many patients might not be aware of is high-dose vitamin A skincare products. So a lot of the things that are used to treat skin blemishes or to lighten the skin contain really high levels of vitamin A, which could theoretically be harmful to the baby. And then specifically codeine-containing products are a very bad idea. Okay. Also in breastfeeding, codeine might be hypermetabolized by the mom, causing really, really high levels to be excreted in the breast milk. And this is one of the few drugs that have caused neonatal deaths simply from being passed on in the breast milk. Next page. Okay. everybody these days loves alternative medications, and there seems to be this idea that because it's herbal or natural, it must be safe. Okay, absolutely bad idea. My advice to pregnant patients would be to stay away from all traditional medication, herbal medication, aromatherapy, simply because there's very little data. The data that we do definitely have is that a lot of these herbal things were actually used to induce abortion in the olden days, specifically pennyroyal, mugwort, wintergreen. Okay, these are not safe things to be using in pregnancy. They're safe as aromatherapy oils if you're only going to be inhaling them. For the most part, you know, if you put them in an infuser or a diffuser at home, or you're using some oil on your pillow to help with your nausea, that generally is probably safe. But avoid those specific ones at the bottom because they're known to induce abortion, and better safe than sorry. Next page. Okay. Then everybody can hopefully know that illicit drugs are bad in pregnancy. This again comes down to patient counseling. And we do have to address the fact that a lot of our patients are in poor social circumstances. They might have pre-existing addictions or substance problems. And we have to be able to counsel patients in a non-judgmental way that these things at least you should be avoiding in pregnancy because of the severe risk to the fetus. Okay, really just something to be aware of in the back of your mind. We don't only need to ask about prescription medication, chronic medication, over-the-counter medication. We should also be asking about alternative medicines and then illicit and recreational substances. Next page. Okay, I promise we're almost finished. This is a very long and busy table that really just tells you a little bit about lactation. The majority of medications, as I said, really get excreted in extremely tiny amounts in breast milk. So almost everything is safe while you're lactating. The big no-nos are really just codeine and tramadol because of the erratic metabolism that I mentioned, and that some patients can be hypermetabolizers and not be aware of that. Suddenly the baby gets an enormous whack of opioids and goes into respiratory depression. And that would be a really, really sad case. Okay. Diphenhydramine and pseudoephedrine, your anti-allergy medications, may decrease your milk supply, which is the only reason that you should avoid them. But everything else is probably okay when you're breastfeeding. Next page. Okay, then a word on vaccinations, because everybody's so aware of them these days with COVID. There are specific vaccines that are recommended in pregnancy because getting the disease is so much worse when you're pregnant, specifically flu. Okay, flu can actually end you up in ICU if you get it while you're pregnant. So please take your yearly flu vaccine even in pregnancy. Same with whooping cough and COVID-19. There is now a mountain of data that shows that the COVID vaccines are all safe in pregnancy. Then certain vaccines under specific conditions, if the benefit will outweigh the risk, specifically rabies if you've been exposed, tetanus if you've been exposed, and certain travel-specific vaccines if you absolutely cannot avoid going to those areas. Okay. Yellow fever generally should be avoided in pregnancy because it's a live virus. But again, getting yellow fever is probably worse than getting the vaccine. So if you can't avoid travel, at least make sure that you're vaccinated. Okay. On the right-hand side there, you guys can see the vaccines that we should avoid in pregnancy are really only the live attenuated virus vaccines. So BCG, MMR, the oral polio, which we really only give to infants, and the oral typhoid vaccine. Okay. The IM polio vaccine, which I don't think is available in South Africa, is actually safe because it's not live virus based. Next slide. Okay, now we're getting to radiation. We're going to start with a teeny tiny science lesson from high school. The electromagnetic spectrum really stretches all the way from our power lines through our radios and TVs to cell phones and up to radioactive materials. And the only radiation we really need to be worried about is ionizing radiation, because that is the radiation that can penetrate your tissues and can actually cause changes and damage to your cells. Okay. Anything below ultraviolet, so below sunlight, basically, is perfectly safe. So please reassure patients that cell phones and microwaves and Wi-Fi are all completely fine in pregnancy because they're non-ionizing. Okay, they can't actually enter the body because the wavelength is too slow. The frequency is too slow. Next page. Okay, a little bit about how we measure radiation. So we measure radiation with various different units, and we really want to look at the absorbed dose and then the dose to specific organs. So the most common unit that's used is grays or rads, and this really looks at the absorbed dose of radiation that actually goes into your tissue. As you see on the right-hand side there, there's a dose specific to the lens from a CT brain is about 60 milligray, so 1,000th of a gray. And the dose of the thyroid from a chest CT is about 10 milligray. Okay, so 10,000ths of a gray. So really, really tiny amounts. Next page. Okay, then we're also looking at the effective dose. So the grays is the absorbed dose, the dose that goes into your tissue. And then the effective dose takes into account the type of radiation and also how sensitive that organ is to radiation. So they've looked at all the various types of tissue and the amount of radiation that they get exposed to, and then what the effect on that specific organ is. And this is measured in sievert or rem. And this is what we use to set the protective levels for people who work with radiation. So all of our radiographers, everybody who works in nuclear plants, anybody who's exposed to radiation in their work has a specific limit, and that's based on the effective dose of what that radiation will do to their specific organs. So the worker limit across the world is 50 millisieverts over 1 year. And if we ever have a nuclear disaster and Kuiberg explodes or something bad happens, then they're going to measure and see if there's more than 10 to 50 millisieverts over 4 days, then we're going to have to evacuate. So that just gives you an idea of how we measure these specific things. Next slide. There's lots of background radiation in the world outside of medical radiation. As you can see there, background radiation, the light blue block, this is radiation that we get from soil and water and the sky. And that's really the majority of radiation that we're exposed to, all from the natural environment. There's also space radiation. There's some radiation from the soil. And then at the bottom there, you can see there's CT scans in purple, which is the biggest source of man-made radiation that we regularly get exposed to, nuclear medicine, and then certain other radiographic procedures at the bottom there. Next page. Okay. Here's a little bit on radiation doses from the various sources, which I found very, very interesting. If you have a look there, a whole body CT right at the top there in millirems. And then going down, there's radiation that you get inside houses, more overseas where people have deep basements and they have double glazing and thick walls because of the cold weather. Radiation can actually build up inside houses just from seepage from the soil. There's radiation from space. There's radiation from terrestrial radioactivity, which is rocks and plants and things. And then right at the bottom there, we're getting chest X-ray and radiation from mammograms and head CTs and so forth. Next page. Okay. This gives you an idea of where dangerous radiation starts. So right at the bottom, we've got a dental X-ray, which is an incredibly low dose. And then all the way through the green, we've got our various medical procedures. And if you look at the start of the yellow there, 100 millisieverts is the lowest possible increased cancer risk level. Okay, have a look. Full body CT is only 10 millisieverts. The lowest risk linked to cancer is 100 millisieverts. All the way at the top there in the thousands is what we get from nuclear accidents like the Chernobyl disaster, the Fukushima disaster, far, 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 far higher than anything we would ever use medically. Next page. Okay, so your risk for childhood cancer at baseline, everybody's risk is 0.2 to 0.3%. 10 milligray, which we said is about a head CT, gives you an increase of 0.05%. So tiny, tiny, tiny increase on top of your baseline risk. Okay, something to be aware of. But unless the child's going to be getting a head CT every day for a year, you probably don't need to stress too much about the increased risk of cancer from radio investigations. Next page. Okay, a little bit about ALARA, which is a concept we should all just be aware of. And this stands for as low as reasonably achievable. And this is what all the radiologists and the radiographers aim for with every investigation that we do. We always want to use the lowest amount of time that someone's exposed The biggest distance, if you're the one doing the x-ray, we shout exposing and everybody runs away. And then make sure that we've got appropriate shielding, both to protect our staff members as well as to protect the organs or the fetus that shouldn't be irradiated. So we're always going to use our ALARA principle for any investigation, not just in pregnant patients, but in every patient. Next slide. Okay, a little bit about myths about radiation dose in pregnancy. It is always better to get the imaging than to avoid the imaging because of some theoretical fear about radiation. If you have a look there at the fetal dose that the fetus will be exposed to from maternal x-rays, 0.001 milligray from an x-ray of a limb, even all the way up to a CT abdomen, 1.4 milligray. A CT angiogram, 0.01 to 0.6 milligray. Okay, these are tiny amounts of radiation. It would take more than 50 milligray to potentially theoretically harm the fetus in any stage, even during organogenesis in those first few weeks. Okay, the bottom line is that you shouldn't withhold imaging if it is appropriate. You should still use the ALARA principle, use the lowest possible dose of radiation, use it appropriately. But if your patient needs imaging, please get the imaging. Next slide. A little bit more about the various doses that you get from various types of imaging. If you have a look at this, have a look at the pelvis. Okay, that's really the only place where we're starting to get a little bit close to potentially maximum doses. And this is important if we're doing a pan scan for a trauma patient, because a pan scan is actually 3 CTs in one. We've got our arterial phase and the whole body gets scanned. We've got a venous phase and the whole body gets scanned again. And then we've got a delay phase while we wait for the contrast to drain from the kidneys into the bladder. And then the whole body gets scanned again. So if you stack those 3 scans on top of each other, now you're starting to get towards doses where you need to be aware of the risk to the fetus. And this is again where ALARA comes in, because you can go and have a discussion with your radiologist and say, look, I'm not concerned about a bladder injury. We can skip the delay phase. The bladder is fine. That's one less CT scan. I'm most concerned about solid organ injury, so I want to see if there's an arterial blush. Let's rather just do the arterial phase pan scan and avoid the venous phase. And by having that discussion and having your pre-examination assessment of where you think the injuries are, you can actually go and have a discussion and see which portion of the pan scan would be the most relevant to you to find the injuries. Next slide. Okay. From the College of OBGYNs in America, this is their recommendation. So ultrasound, always first choice. We know it's safe. It's widely used in pregnancy. And although your EFAST is not as sensitive in pregnant patients, it can still give you an indication of what you want CT'd. Okay. MRI, fantastic option, except that we don't have it freely available in the ED. It's not commonly available after hours, and it can take very long to do an MRI. So it's not a great option for trauma. If you've got non-urgent imaging, then potentially consider using sonar and MRI instead of CT scan because of the decrease in radiation risk. Okay. At the second point there, even the OBs and gynaes say that with a few exceptions, radiation exposure is at a much lower dose than that associated with fetal harm. If these techniques are necessary, they should not be withheld from the pregnant patient. Then a little word on the use of gadolinium contrast, which is a radio contrast that they use for MRI. Not really so relevant for us in the ET, but just to be aware of, still says use it if it is necessary. And then breastfeeding does not need to be interrupted after contrast administration, because as we said previously, very little of anything that we use actually passes into your breast milk. Okay, so the bottom line is if your scan is clinically indicated, you've examined your patient, you've used your sonar appropriately, and you still feel that there's an injury that you cannot exclude without CT, please do the CT. Next page. Okay. If you guys want to go and read further, here are all the sources. They've got all of those tables that I posted. If you want to bookmark them and keep them in your phone somewhere, it's always good to have a reference source. And that is the end of my talk. Any questions? no questions. Okay.
Thank you, Dr. du Plessis. I really appreciate that you came and gave your talk for us, even though we started off with some IT issues. It was a great talk and obviously particularly relevant for where we work. Does anybody have any comments, even if they don't have a question for Dr. du Plessis?
Nope. Okay.
Thank you so much.
Thank you so much for your time.
Yeah, it was really awesome. Thank you very much for joining.
Thanks so much
Thank
for
you so
having
much.
me. Cheers, guys.
Thank you, Jana.
Thanks,
Big
Jana.
pleasure.